Hello and welcome to this channel. My name is Victoria, and in this video we will talk about pelvic inflammatory disease. Pelvic inflammatory disease is an inflammatory disease of the upper genital tract in women. It is usually an ascending infection that originates in the vagina or the endocervix. It affects primarily women between 15 and 25 years of age and is in most cases caused by a sexually transmitted infection such as Neisseria gonorrhea, Chlamydia trachomatis, and Mycoplasma genitalium. Around 15% of cases are caused by non-STI agents such as bacteria of the normal flora of the vagina or cervix. PIDs that are caused by other agents than STIs often happen spontaneously or during birth. Pelvic inflammatory disease is an umbrella term as many different structures within the female reproductive system can be affected. Those are the cervix, the fallopian tubes, the ovaries, and the uterus. In case the fallopian tubes and ovaries are affected, we also call it adnexitis. The adnexa uteri are the ovaries and fallopian tubes, as well as the vessels, ligaments, and connective tissue around the uterus. What are symptoms of PID? The symptoms of pelvic inflammatory disease range from mild to severe and potentially life-threatening. The most common symptoms include abdominal or pelvic pain, vaginal discharge that might have an abnormal odor. The odor depends on the agent that causes the PID. Also, vaginal bleeding after intercourse or in between two menstruations is possible. Many patients also experience dysuria and urinary frequency and fever, together with nausea and vomiting. How do we diagnose PID? When pelvic inflammatory disease is suspected, a general physical examination and a gynecological examination by the use of a transvaginal ultrasound should be done. We should suspect a PID when a patient has a uterus or adnexa of the uterus that are sensitive to pressure in a bimanual examination. Also, a microbiological investigation is recommended. However, a negative microbiology does not exclude a PID, as also the bacteria that are normally found in the reproductive system can cause a PID if they cross through the cervix into the uterus. In a laboratory examination, usually a high leukocyte count and a high CRP can be found. When we suspect a PID, we should also make a pregnancy test to exclude a either normal or ectopic pregnancy. To make a definitive diagnosis, also a laparoscopy, CT scan, or MRI can be done, but it's not routinely recommended. To help to make the diagnosis, there's a classification of major and minor criteria. The minimum diagnostic criteria are the ones that have to be present to put a diagnosis of PID. Those are that the patient has pelvic or lower abdominal pain, together with a cervical motion tenderness or adnexal or uterine tenderness. The additional diagnostic criteria support the diagnosis but are not essential to make the diagnosis. There are 5 additional criteria. Those are: first, fever over 38.3 degrees Celsius. Second, a mucopurulent discharge. Third, leukocytes present in the vaginal fluid. Fourth, elevated inflammatory markers in the blood. And fifth, microbiology that confirms a STI with chlamydia or gonorrhea. What are some differential diagnoses? In case of symptoms that can indicate a PID, we should also suspect an ectopic pregnancy, complications of an ovarian cyst, an appendicitis, irritable bowel syndrome, endometriosis, cystitis, ovarian torsion, or a pyelonephritis. What are complications of a long-standing PID? If PID is not treated quickly, or if the patient experiences recurrent PIDs, this can lead to a series of complications. They include a tubo-ovarian abscess, peritonitis, ectopic pregnancy, chronic pelvic pain, and infertility. Recurrent PIDs usually develop when either the treatment was ineffective or terminated too soon, or if the patient has a partner that wasn't treated, or has several partners that contract one of the STIs repeatedly. Recurrent PIDs are usually associated with a higher risk of developing infertility. The abscesses in PID are caused by pus that travel from the vagina or cervix upwards to the fallopian tubes. This pus is usually formed in an STI, and if untreated, it can lead to complications. The pus can also move to the peritoneal cavity and can cause an inflammation and abscess formations there. Also, scar tissue can form in the fallopian tubes, which can partially or completely obstruct them. The abscess formations or scar tissue can make it difficult for an oocyte to pass from the ovary through the fallopian tube to the uterus. That's also how a PID can promote the occurrence of ectopic pregnancies or infertility in the case of a complete obstruction. Chronic pelvic pain and chronic back pain are related to inflammation, scarring, and the formation of adhesions in the pelvis when the infection spreads to the pelvis. This is most often the case in recurrent PIDs and is seen in around 1/3 of patients that have experienced a PID. How can we treat PID? After we diagnose pelvic inflammatory disease, we should initiate a treatment with empiric antibiotics that cover Neisseria gonorrhea and Chlamydia trachomatis. The treatment is usually initiated before the microbiological results are available, and if necessary, the antibiotic can be changed at a later point of time. The usual antibiotics that are given are cefoxitin, which is a second-generation cephalosporin, in combination with doxycycline. Cefoxitin has a better anaerobic coverage than ceftriaxone. An alternative combination of antibiotics is clindamycin together with gentamicin or ampicillin together with doxycycline. The antibiotics are usually taken for 14 days. Also, NSAIDs can be prescribed for the pain associated with PID. That's it for this video. I hope it was helpful, and if you like our channel, please subscribe. Thank you for watching, and hopefully see you again in the next video.